Oh, hello, ladies and gentlemen. Thank you for the invitation to address your conference today. I've been asked to summarize within 30 minutes why do we really want to reduce salt consumption in our diet. To start the conversation, let us agree on the terminology to avoid confusions. We should refer to sodium and salt. However, they are not the same thing. Sodium is a cation, and it is what we want to reduce for its health effect. It is mainly consumed as a component of the sodium chloride salt, or salt, in our conversation. But just remember that 1 gram of sodium is contained in 2.5 grams of salt. But salt is not just the white stuff that we're used to, like you see here. We often find in nature a variety of appearances of salt, and these are only some of them here. All contain in excess of 97% of sodium chloride, which is a substance that we think is not very healthy. None of them have healthy properties, and none of them have any magic effects. All contain more than 97% sodium chloride. So the first question to answer is, what is a normal salt consumption? We should make a distinction between what is normal and what is a usual salt consumption. No one has a normal salt consumption if we intend to refer to the salt on human ancestors when eating regularly in the past. In modern times, very few humans now live that condition of our ancestral parents. One example studied is that of the Yanomamo Indians, which I showed here in this picture. This is a tribe living like our ancestors still in the Amazon jungle between Venezuela and Brazil. They live on an evolutionary diet with less than 1 gram of salt per day, very little fat, no refined carbohydrate, and plenty of potassium and fiber from fruit and vegetables. Hypertension is rare, there is no rise in blood pressure with age, and vascular disease is almost unknown. The male's adult's average blood pressure recorded directly in studies done in the 80s was about 96/61 millimeters of mercury. And incidentally, their average cholesterol was also very low at 3.1 millimoles per liter. So human beings can live with such a little amount of salt. So normal salt is around 1 gram per day, but usually we eat far more than that. Most of the salt we eat, in excess of 75%, derives from salt added to food rather than from natural sources. Only about 12% is natural, and another 11% is added by us when we cook or when we add salt at the table whilst or before eating food. Now, as you probably know, one of the priorities worldwide is to reduce the burden of cardiovascular disease, which is the first killer in the world through coronary heart disease and stroke and kidney failure. One of the priorities to achieve that goal of reducing cardiovascular disease is to reduce population salt consumption, which has been set by at least a 30% reduction by 2025, with a long-term target to reach no more than 5 grams of salt per day. Now, what is the evidence to justify such a public health measure? And I'll take you through in a few minutes to assess the evidence. We know from observational studies that high salt intake is associated with high blood pressure. The association is not a proof that eating more salt causes the blood pressure to rise, and more importantly, does not prove that if we reduce the amount of salt we eat, we would reduce blood pressure. So the first randomized trial to confirm the cause-effect relationship between the two is shown here. Hypertensive patients at the time were randomized to 3 different levels of salt intake, 3, 6, and 10 grams of salt per day, each to be sustained for a month, as shown in this panel here. The bars indicate the 24-hour urinary sodium excretion averages, which is a marker of salt intake to indicate adherence to the randomized level of salt consumption. The top represents systolic and diastolic pressures at the end of each monthly period. And as you can see here, the lower the salt intake, the lower the systolic and diastolic blood pressure, suggesting a very powerful and natural way of lowering blood pressure in hypertensive patients without the use of drugs. The indication of a sustained effect was given by the evidence in the right panel that if salt reduction was sustained over a year, when these people were maintained at the lower level of salt, 3 grams per day for a year, the blood pressure would remain lower. Many have suggested that not all people respond in the same way to a reduction in salt consumption due to their individual salt sensitivity, with some even showing a rise in blood pressure when reducing salt consumption. The distribution of the blood pressure response to salt reduction follows a normal distribution, as shown in the left panels here. The distribution shifts to the left when reducing salt intake and on the right when increasing it, with an average response that moves in the same direction, lower on low salt and higher on high salt. However, this response within an individual is variable from time to time, so that it is not possible to categorically classify an individual as salt sensitive or salt resistant. In other words, none of the methods used to classify people are sufficiently reproducible within an individual and over time to characterize salt sensitivity as a dichotomous yes or no variable. Therefore, there is a limited scope in the clinical settings to attempt to identify individuals for a targeted approach. On the other hand, there are some characteristics that predict a greater response to salt reduction. For instance, older age, African ancestry, being overweight, have a higher blood pressure, or having type 2 diabetes. Since the first trial I showed you, more than 100 clinical trials have been carried out and many meta-analyses have been published, as listed here. Their results, irrespective of different inclusion and exclusion criteria, showed a very consistent and compatible with each other message. Reducing salt intake lowers both systolic and diastolic blood pressure. The effect of reducing salt intake on blood pressure is dose dependent. The more you reduce your salt consumption, the more the blood pressure falls. And that's a very important concept. The blood pressure effect of salt is reflected in a detrimental effect on cardiovascular outcomes. Here we have the first published meta-analysis showing the prospective relationship in large population studies between high salt consumption and incidence of fatal and non-fatal strokes. A difference in 5 grams of salt per day, like for instance going from 10 grams to 5 grams per day, in these particular groups here was associated with a 23% difference in the incidence of fatal and non-fatal strokes. In other words, a lower salt intake was associated with a lower incidence of stroke rates. In further prospective studies, and this is the TOHP study in particular, the relationship between salt consumption measured by multiple 24-hour urine collections for sodium determination and both cardiovascular outcomes in this left panel, or even all-cause mortality in the right panel, proved to be graded across the range of salt consumption seen in most populations, which goes from, let's say, 2 to 3 grams of salt per day upwards. And finally, A few randomized clinical trials where it was possible to measure the effect of a period of salt reduction on vital cardiovascular outcomes clearly indicate a statistically significant 20% reduction in total cardiovascular events, as predicted from previous observational studies. There have been claims, and I have to mention that, of a J-shaped curve between salt intake and cardiovascular mortality, with suggestions that moderate salt reduction could be harmful. These claims are based on flawed methodologies, leading to erroneous results as shown in this slide. On the left here, we see the bias in blue with a blue arrow introduced when using spot urine collections to derive usual salt consumption compared to the gold standard use of 24-hour urine collections as a marker of intake. There is a large overestimation at low levels of intake and a very gross underestimation at the higher level of intakes. This bias leads to a spurious J-shaped association with mortality, as showed in this panel here with the red arrow, which is not present, on the other hand, in the graph on the left arrow, when in the same study you use 24-hour urine collection to estimate intake. And that's clearly this association is a direct result of the artifact of using the wrong method to estimate salt consumption. Furthermore, the use of a spot urine collection would not have the same power to detect small but important changes in average sodium excretion over time in repeated population surveys. Spot urine would fail to detect important effects of salt reduction strategies, as shown in all these examples in a Chinese study using different formulas based on spot urine, compared to the same estimate for the same study using 24-hour urine collection, which is able to pick up a small but significant difference in the program over time. This problem would have a negative implication in supporting further action to strengthen public health policies, and would fail to detect even small but potentially significant effects when you look at population level. So it's not advisable to use spot urine in these settings. So salt reduction is a preventive imperative. Since salt intake is higher than needed, its reduction causes a dose-dependent reduction in blood pressure. It is associated with lower cardiovascular event, and it is feasible and effective. Now, this map represents the cost-effectiveness of government-supported policy strategies to reduce salt consumption in populations. The strategies mainly include soft regulations like targeted industry agreements, government monitoring, and public education. And globally, a 10% reduction in salt consumption over 10 years is estimated to avert nearly 6 million DALYs per year attributable to cardiovascular disease. DALY stands for disability adjusted life years, for an average weighted cost of about 1.1 international dollars over 10 years, making the strategies affordable everywhere. Obviously, the economic benefits due to reduced healthcare as well as social costs will vary across countries. And the blue color in this slide indicates the areas of the world where the strategy not only would be cost effective, but in fact would be cost saving in these particular settings. So from this and other evidence, which I haven't got no time to go through, there is an economic imperative to reduce salt intake. In every country studied, there will be a significant return on investment. It would be cheaper than using medications. If harder strategies were used, like for instance mandating food reformulation from the industry, and we have examples, for instance, in South Africa where this is going on, it would even be cost saving. Now, this slide shows the important components of the strategy being adopted by the World Health Organization and most national health organizations to reduce the population consumption of salt over the next few years to achieve a reduction in salt intake towards the final targets of no more than 5 grams per day. This strategy is often defined as the three-pillar approach strategy based on communication, reformulation, and monitoring. And these three pillars will be supported by continuous research to provide new evidence to inform further action. Communication involves mainly public health awareness campaigns and, directed to consumers, the food industry, decision makers, media, and health professionals. The reformulation pillar aims to improve the quality of food by reducing the salt content of commercially available food by setting targets of salt content of benchmark food categories in collaboration with the industry in the first instance, using what we call a voluntary approach. Or, if not, if steps forward are not achieved, by regulatory actions. And the last pillar is the monitoring and surveillance, aims at measuring salt consumption in populations with repeated surveys to demonstrate the effective impact of the policies, and then measuring the salt content of reformulated food categories to demonstrate the effectiveness of the reformulation activities. And the stage of the Lithuania approach, I think, today is going to celebrate one of these achievements. Is the first national survey for assessing salt consumption in your country. In 2003, the UK government launched a national program of population salt reduction, which included public awareness campaigns, setting voluntary targets with food reformulation, and regular monitoring and surveillance of salt consumption and salt content of food. And after 8 years of this campaign, at least in England, this is a measure for one of the 4 countries in England, salt consumption was reduced by an average of 1.4 grams per day across the whole nation. During the same period, there was a steady trend in blood pressure reduction, as you can see here, and a 40% reduction in ischemic heart disease and a 42% reduction in strokes. Obviously, we don't say that it was all attributable to salt reduction, but there was a modeling estimate that indicated that the effect attributable to salt reduction would have averted about 9,000 fatal vascular events every year. The effectiveness of this program, measured by the amount of salt reduction achieved, which we see on the y-axis, becomes greater and cheaper the more upstream measures are implemented, like the involvement of the industry with either voluntary or mandatory reformulation of benchmark food categories. As many other dietary factors associated with cheap, unhealthy junk food, also for salt, there is an association between high salt consumption and low socioeconomic status. This evidence is shown here for Great Britain on the left and for Italy on the right in 2 different population studies. The evidence is consistent whether we define socioeconomic status using occupational parameters or educational attainment. In addition, in Britain, we had a 10 years follow-up study, which allowed us to compare the association before and after the national strategy. And salt reduction was spread across all social classes, but still the gradient in social class remained untapped, the inequality, with the program that we had in Britain, suggesting that there are other ways in which we can increase the equality and the equity of the distribution of benefits. And one of the reasons whereby social inequalities in salt consumption were not reduced or abolished is in part attributable to the fact that in Britain there were no mandatory measures for reformulating. This graph clearly shows that using different modeling scenarios, the socioeconomic gap can only be significantly reduced here if mandatory reformulation was considered as the green estimate compared to the effect of the voluntary reformulation. So there is a political imperative to reduce salt consumption. The effect is rapidly achieved with substantial health benefits and could help reduce social inequalities. Finally, let us put together the different figures I've flashed to you so far. Salt consumption greater than 5 grams per day, or the equivalent of 2 grams of sodium per day, is currently responsible for more than 1.65 million deaths from cardiovascular disease globally. And this is about 10% of all cardiovascular disease mortality, which in turn is the leading cause of death globally. More than 80% of these deaths, however, still occur in low and middle income countries, those with the greatest burden of disease and the least resources to tackle it properly. So I end up with this moral imperative, which is justified by a simple statement that population salt reduction, the reduction problem, save lives. Now, before I close, I want to share some implications on why it becomes more difficult internationally to reduce salt consumption. This slide shows who owns what in the food industry. Most globally marketed food and beverages products, and you can recognize many, many labels here, are in fact owned by only 10 large multinationals, which are these little marks in the center here. You recognize most. They collectively feed every day several hundred million people in over 200 countries, generating a combined annual revenue in excess of $400 billion. And this is an estimate calculated in 2012 from their own sources. Given the large profits involved, let us briefly consider why controversies on the role of salt on health may result more beneficial to the food and beverage industry than to the public health agenda. High salt is in processed and manufactured food leads to profit to industry with several mechanisms and for several reasons. And this cycle of profit scheme illustrates how salt in foods generates profit. By increasing palatability and taste addiction, as a cycle in red, it will produce profit. It makes bad food edible and increases demand. Through its hygroscopic properties in blue, the ability to retain water, salt will increase the water content of meat products with increase in weight and no extra cost, which should be sold at the cost of meat, generating profit. And also salt will generate thirst in green, increasing drinking, including high energy sugary as well as alcoholic drinks. And it's no surprise, if you see from the previous slide, that most of the food industry also own the beverages, or vice versa. The beverage industry owns the snack industry as well. This latter effect is now known to be a contributing factor in fueling obesity as well, both in adults as in children and adolescents. In adults, reducing salt intake by half, let's say from 10 to 5 grams per day, as indicated by the WHO, would reduce fluid intake by about 350 milliliters per day per person. That is the amount equivalent to a single can of soft drinks per person per day. In children, a difference in 1 gram of salt intake is associated with a difference in 100 milliliters of fluids and 27 grams of sugar per day in terms of consumption. If salt intake in children in the United Kingdom was reduced by half, let's say a reduction of 3 grams per day, there would be an average reduction in approximately 2.3 sugar-sweetened soft drinks per week per child, which would be removed from the energy supplying the epidemic of obesity. But you can rapidly work out the profit loss to the soft drink industry, and therefore the, let's say, the antagonism that some of the industry has in implementing national programs or global programs of salt reduction. So in conclusion, I can say that salt consumption is much higher than needed. Reduction in salt consumption causes a dose-dependent reduction in blood pressure, and lower salt intake is associated with lower morbidity and mortality from cardiovascular disease. The population salt reduction program are feasible and effective, as cost savings in all settings, are powerful, rapid, and equitable, are life-saving. So a reduction in salt recommended for the prevention of cardiovascular disease, as stated by WHO, aims at reducing salt intake by 30% within the next few years by 2025, but the final aim, based on evidence and health gains, is to reduce it below 5 grams per day. Thank you for listening.